Hello, welcome back to our learning channel for MLSQR. And today we're going to talk about sideroblastic anemias, lead poisoning, porphyrias, and more. And afterwards, we'll have a good question and answer period. Let's start with the bone marrow aspirate and slide, taken after a clinical suspicion and initial workup. The hallmark of sideroblastic anemias are the ringed or ring sideroblasts seen in a Prussian blue iron stain of the bone marrow, where iron granules form in the mitochondria surrounding the nucleus of erythroid precursors. FYI, sidero is a prefix meaning constellation in Greek, and in ancient Greek mythology, Sidero was the iron one. Anyways, it is important to note that a diverse group of diseases interfere with protoporphyrin production, which can lead to sideroblastic anemias, which are usually microcytic and hypochromic. Let's also look at the peripheral blood smear in an automated CBC analyzer with automated differential. Do you see basophilic stippling? Let's look at the microscopic slide. Lead poisoning is an acquired sideroblastic anemia, which we see as evidence in the peripheral blood smear in the form of many red blood cells demonstrating basophilic stippling, which are aggregates of ribosomes with RNA in degenerating mitochondria, staining with a punctate blue pattern seen in a right Giemsa stain. Pappenheimer bodies can be seen in sideroblastic anemia. They are iron deposits with irregular clusters of small light to dark granules, seen in the right Giemsa stain. You can also stain this with Prussian blue stain for iron. What are the sideroblastic anemias? How are they classified in the context of all the anemias? What are the key diagnostic lab tests to help diagnose these anemias? We'll use the CBC definition of anemia, where there's a decrease in the red blood cell count, hemoglobin, hematocrit below reference ranges, and we'll use the ASCP border certification reference ranges. The differential diagnosis for microcytic anemias are included. Iron deficiency anemia is the most common microcytic anemia. Now, if you see at the bottom sideroblastic anemias, they are hereditary or acquired. Lead poisoning, alcohol, drugs, and toxins inhibit enzymes critical for protoporphyrin and heme synthesis. Myelodysplastic syndrome may cause secondary sideroblastic anemia. Ring sideroblasts in the bone marrow of a Prussian blue iron stain is not a healthy sign. It is a sign of disease. There is plenty of iron available in the mitochondria, as you can see, but it cannot be incorporated into the hemoglobin as ferrous iron, as we will see in detail later. Ferrous iron is waiting and accumulating to join with protoporphyrin 9 to form a heme molecule. Here's a quick review of erythropoiesis. In that context, let's focus now on hemoglobin synthesis. While reviewing hemoglobin synthesis, note the important enzymes, substrates, and products in the biochemical pathway that occurs in the mitochondria and cytosol of the erythroid precursors. To the left are the reactions for the ones occurring in the mitochondria, and to the right in the cytosol. And we will emphasize that you don't have to memorize everything here in the biochemical pathway, but at least know some important defects in hemoglobin synthesis that will lead to a sideroblastic anemia. Transferrin is a carrier protein that carries ferrous iron in the 2+ valent state to join protoporphyrin 9 to form heme, which will join 2 alpha globin chains and 2 beta or 2 non-alpha hemoglobin chains to form one hemoglobin molecule that can carry 4 oxygen molecules from the alveoli of the lungs to our tissues. We probably don't want or need to memorize everything in this biochemical pathway, but at least know the three key enzymes affected by lead poisoning, and at least that an enzyme defect in hemoglobin synthesis will lead to a sideroblastic anemia with basophilic stippling in the red blood cells. Here's an easier way to look at the hemoglobin synthesis pathway. Lead is a significant public health concern where children were eating paint chips made from old lead-based paints, and adults were exposed to when they had renovations and paint dust. And then we see this now in old lead leach from service pipes by improperly treated drinking water. Question: which three enzymes are poisoned by lead? Do you know which ones? If you guess ALA dehydratase, coproporphyrinogen oxidase, and ferrochelatase, you're correct. When lead, a blood poison, inhibits these three hemoglobin synthesis enzymes, there is a backup of substrates, an accumulation of aminolevulinic acid, protoporphyrins, and iron granules around the mitochondria of the erythroblasts, which we see as ringed sideroblasts in the bone marrow Prussian blue stain. What do you think are the key diagnostic tests for lead poisoning? Urine, ALA, aminolevulinic acid, free erythrocyte protoporphyrin, zinc erythrocyte protoporphyrin, and blood lead levels. We may ask, what does zinc protoporphyrin have to do with hemoglobin disorders? When there is an inhibition of ferrochelatase and iron is not chelated, zinc competes with iron to chelate to protoporphyrin, forming zinc protoporphyrins. This also happens in iron deficiency anemia. Porphyria comes from the Greek word porphyra, meaning purple, and it's referring to the purple urine during an attack. Inherited metabolic disorders involving the buildup of porphyrins adversely affecting the skin or nervous system. The purple urine appears after exposure to light after several days, and you can see there's a long list of these porphyrias. Porphyrin and porphobilinogen screen are good screening tests for porphyria. Screening tests are usually an initial battery of tests when there is a clinical suspicion of pathology, so signs and symptoms with initial CBC lead the clinician to order more screening tests. Screening tests are usually sensitive with a low threshold value, but not as specific as confirmatory tests. Also, screening tests are usually qualitative, not quantitative. I noticed in the ASCP study guide that there were several questions about lead poisoning, but only a few about the inherited porphyrias. One was a general question that asked about an enzyme defect in heme synthesis pathway. One question in the general chemistry section stood out about a specific porphyria, hereditary coproporphyria. In hereditary coproporphyria, the enzyme deficiency is coproporphyrinogen oxidase, and the accumulation is coproporphyrin 2 in feces. If you try to recall the biochemical pathway and the enzyme deficiency, then you can think of the substrate accumulation. And this is the coproporphyrin 2, and it's in fecal matter. Well, we've covered a lot of clinical lab science material, and now we'll see if you're ready for some Q&A. And these questions are designed after the ASCP Board of Certification exam. They're not quite exact, but they're similar. Thank you for your time and attention, and I hope we both gain from this experience, and I hope to see you in the next video.